Thank you for all getting up bright and early for this presentation today. Also, thank you to Mark, Elizabeth, Bellin College for helping us host this presentation and the recording of this presentation. And of course, thank you to Dr. Mick Spears for presenting this morning.
What?
Yeah, he. Mick Spears.
Oh. That was last year.
Yeah. All of St. Patty's Day related this year. So just a few housekeeping items. If you haven't helped yourself to juice, coffee, donuts, please do so. Bathrooms are located across the hall. Then you should all have Dr. Spears' presentation, a quiz, and a survey in front of you. I can pass it out if you don't have it. The packet in front of you doesn't include all of his slides, just because a lot of his slides were also videos of surgery, so we don't want to include those to save on ink. But if you want a copy of this presentation, we're recording it and it's on the drive, so we can share that with you. Following the presentation, we'll have a question and answer session, and then you'll be able to complete the quiz and survey, and then we'll collect those at the end. So now for our presenter, Dr. Spears. He's a fellowship trained orthopedic surgeon with a sports medicine specialty. While he works with a variety of sports medicine injuries, his main focuses are shoulder and knee injuries. He has served the Green Bay community for over 25 years. I have worked in Dr. Spears' practice for, I believe, 3 years now. I have witnessed that he is truly an artist of the shoulder, as he is often referred to by our peers. His attention to detail, extensive knowledge, and clinical expertise of shoulder treatments and surgical techniques are second to none. Please help me welcome Dr. Spears.
Thank you. Well, I think about half of that's true, but thank you, Allison. So my plan today is to kind of talk about shoulder, and you can. There's probably 10, 15 topics we can talk about, each one of which you could have a whole lecture on. So I really just want to try and hit the high spots of what are all the different shoulder injuries that we think about, what's kind of pertinent to you. I really think the best part about this is, to me, is always the question and answer at the end, because it's hard to drill down to what you're doing and what you're seeing in the training room, and what are your responsibilities and what should you be thinking about. So my whole idea is to say, okay, well, when they leave you, what do we do with them, and how do we handle them, so you can see kind of what that's all about. That way, when you're educated to it, you can help them understand when they come to our office what's going to happen. So see if this works. Uh-oh.
I'll click on it.
All right. So yeah, so I've been here incredibly more than 25 years. So hard to believe, but that's where I am. And then this is the wonderful building I get to work in. So I think everybody's seen Titletown before. So that's been a really great thing. This is truly incredible place for people to come to. People are marveled by how it is when they come in there. It's been a really fun place to work, and looking forward to continuing to work there. So kind of what do I actually do? And, and the answer is, Allison said, is I kind of do shoulders and knees. But, when you do sports, that means you just kind of take it all on. We're unique in Titletown in the last year or two that we've really hired tremendous specialists, though. I used to take care of little pinky injuries and things because, a basketball player gets injured and whatever. We now have 2 full-time hand and elbow surgeons. We have 2 full-time foot and ankle surgeons. So, in my world, in my life, I still manage foot and ankle stuff, ankle sprains. It's just what happens. You see people for low back pain, the kid that's lifting in the weight room, it hurts his back, you see that. So we take care of all those aspects, but from what do I do surgically, shoulders and knees. So we're gonna really just focus on the shoulder thing. And these are the learning objectives we were talking about, just kind of understand the cause of injuries, understand what do we do to figure them out, from diagnostic techniques and exams. And what are the appropriate treatments we do, and then at the end, I'm going to talk about and show you kind of how do we do a surgery, how do we fix a shoulder, and what does that all mean. So injuries, this is kind of my list of issues, starting top to bottom. I'm actually hit all of these, but there's certain ones I think are going to be really important to talk about versus other ones. And I was going to hit the first ones. We start down here bottom and check these 2 off. And so inflammation and infections and loose fragments. So inflammations, autoimmune disease, it's a really strange thing. This is people that have psoriatic arthritis, they have rheumatoid arthritis, there's lupus, and there's a much bigger group of people now, younger, so this can be the kid that comes in that's had a swollen ankle, a swollen wrist, both, one or the other. And usually there's no reason, why, they're just there and they're sore and aching, they can't go. And so you just have to be thinking about this, that these are not very common things, but the autoimmune issues come on, and sometimes they'll know they've had it, but other times you might be the first person that sees it. And especially that kid that doesn't really have a reason to have it, it has that swelling, that's what you want to think about. Sexually transmitted diseases. I've had 2 of them with knee gonococcal infections come in, playing football. Knee is sore as heck and all swollen. Been treating it for a week and the swelling won't go away. And what's going on? And do an MRI, not a thing going on there, nothing else. We don't usually ask them, tell me your sexual history, what you've been doing the last month. That's just not something that comes up. But then for us, we see this swollen knee with no reason. We put a needle in there and we get bacterial infection with gonococcal infection. So they're very low grade infections. It's not like a staph infection where they get all hot and sweaty and red and have temperatures of 103. These can be very, very indolent and under the radar. But, and we've had one in a shoulder and we've had one in the knee recently. And so it's not an uncommon thing and it can happen. And these kids in high school, they're in that age group of sexually transmitted diseases occurring. And then the other one is Lyme disease. Lyme disease is a tick bite from the brown deer tick. It is all over Brown County and all over the North Woods and everything. And again, these are the typical kids. Very often, they do not have a history of being bitten by a tick. They have no idea what it is. Occasionally they will. And the typical story is they got bitten by a tick. They saw it, they pulled it off, and then they get a little round target. Wherever they got bitten by, the target will show up. It looks like a little red circle. And that's almost pathognomonic of potentially having Lyme disease or having the tick bite. But many of them do not. And again, it has to be that high index of suspicion. So for me, when I see that kid that comes to see me young and they have a swollen joint, that is not right. They're not going to have a swollen joint. They can if they get injured, but they're not. And when they have a swollen joint and you can't figure it out, you have to think along these lines. And so we actually do, we have a rheumatology panel that we do in our office. We have a tick panel, and these are all medically derived things that you have to really be thinking about it, because these kids could hang out in your training room for a month and be undiagnosed and unknown. So a month of swelling is not what you should be having. Loose bodies, I don't think this is pertinent, but people always hear about what are loose bodies, and you can see this is a disease called synovial chondromatosis. And so the synovium becomes it's not malignant in that it's cancerous, but it becomes malignant in that the synovium starts producing cartilage cells, and then these grow inside the shoulder. And I've had kids that will come in with a painful shoulder and they'll have 100 loose bodies like this in their shoulder. And so it's a problem because they will develop arthritis later in life. But as a young person, we have to scope and go in there, and you spend about an hour trying to get all these little loose bodies out. So again, nothing you would know about, but if you hear about loose bodies, this is kind of what they look like when you're in the shoulder. So strains and overuse. This has got to be the most common thing you're going to have, that you're going to figure out, somebody's coming in and I don't know, it's just sore, it's achy and whatever. And so sorting through that is what you have to do. And so why does this happen? Well, it's usually because they do too much. They're playing year round. A lot of my things here are talking about baseball. That seems to be a lot of the issues with throwing and things that come into this overuse problem. But it's good. The girl who's hitting volleyball serves, and the guy who's throwing baseballs and the girl hitting tennis is all the same. But they play year round, extended times of play, like playing tournament play, 3 games in a day or whatever. The other things too are, playing on multiple teams. They might play on your team here, but they play on 2 tournament teams in Chicago, and I have that. The family's going, well, we can't come in for our appointment because we'll be in Chicago playing another tournament, but we got to get back to play at the high school game on Tuesday, so this extra time, poor diet, lack of sleep. This is the classic, the guy's too tired to play pitcher because his arm is sore, so they take him out and put him at catcher, so because he's a really good catcher too. And then high leverage situations, and then this high pitch count is kind of more akin to the baseball thing. So what is this, the high leverage? Well, it's all about tournament play, pressure, loaded bases, a tight game, and you're being called upon to do it. And research has looked at these things in regular season injuries and tournament injuries and whatever. And there's a significantly increased risk of injury in that. And so you have to be able to kind of appreciate that situation, that these kids may be more at risk for these injuries and overuses and strains, even though they're doing what they did all season, but this leverage situation makes it worse for them. So warning signs are kind of decreased performance, slow reaction time. The pitcher can't find the plate anymore. The volleyball girl can't hit it in when they serve anymore. And there's always this can't get loose. They're tight, and you just know, you call it, well, you're just nervous. But this nervousness then translates into them potentially getting hurt because they can't overcome that part of it. And it's just a seasoning thing. They have to get, your seniors do better at it than your freshmen do. And so, but recognizing it and helping them work through that loosening up is important. So, getting to the baseball pitchers, the decreased velocity, extra time between pitches, changes in breathing. You can see that kid who's, can't pull the trigger on doing what they're supposed to do. So these are all the signs of those things. And I guess the point of this is just trying to recognize it and either counseling them or going to the coach and saying, can we somehow give this kid a break and get through it? And that's really what you're trying to do, is help them out, because sometimes they just need a time to rethink it, get through it, get them out of their high leverage situation, and if you can, and then go back to it. These are the pitch count things you can talk about. People talk about this is super important. Different age groups have different number of pitch counts, and this is probably amenable to all kinds of things. But in baseball, we talk about it a lot more, and you can see we start at age 7 and we go up to 22. So it's important throughout. So solutions, fueling properly. I can remember being on the sideline at football games, and it's the second quarter, and overhearing 2 guys going, man, I'm starving. I wish I'd have had something to eat before the game. And, and it's just, and we don't have, we're not professional things where we have all kinds of food and drink and everything available. So these high school kids are really required. A lot of times they're on a bus going somewhere, and they get there, and, their food is going to be a burger and fries, and that's really all they've got, and for what they normally eat is probably not proper fueling of what they need. Being aware of it, prepping for play and cross training are all important. Fueling properly means they need to get the energy they have. I don't know what your budgets are or how you do it, but being able to have the granola bars, the protein bars, I think we all have Gatorade and stuff at our games now, but I think that educating them to, hey, you need a pregame meal because the school may or may not provide that to you. So you need to make sure you're getting that. And how do you encourage, and that's educational before the season starts, so they become in the habit of it. Because I think a lot of them will just skip it and think, oh, I'm good to go. I'll have something after the game. And the fueling properly does make it a problem. The other part is our conditions. We live in Wisconsin. Most of the time it's kind of cool outside and it isn't that hot. But sometimes in August, we get hot days. It could be 96 degrees. These kids are used to playing football at 76 degrees. And at 96, this hydration thing becomes a huge problem because they're just not attuned to how much fluids they need to drink and the Gatorades, and they do need not just the water but the electrolyte mixture. And then this heat burns more energy, and they need more calories. So again, and what we're trying to do by this fueling properly is that we know that them getting tired, them being hungry means they get more injuries, and so preventative is what we're looking for. And then kind of being aware, trying to help a player with what's the difference between pain and soreness, and if there is a difference. But to me, soreness is what you get because you worked out hard and you expect it because you're trying to get better and stronger. But the next day you can come back and do it again. Pain to me is I have a hard time playing to the next day because I really can't put weight on my leg or I can't really use my arm. And you want to sort those out because we really don't want players playing with this. This is okay because that's expected. But when they've been injured, they need to be able to pull that out. And so I think that the sign of this is this lingering thing, that it's okay to be sore and achy, but hey, come back and check with me tomorrow and they look good. You're probably good. But if they can't put weight on it, they can't use it. I think you need to intervene and say, well, let's just sit down for a day or two because you're better off taking them out, letting them rest, than to try and force through the pain. And I know you've got coaching pressures and things that drive that, but you still need to be in charge of that part of it because that's kind of where you can help them out. And then, send them to us if you need to. That's the beauty of Titletown is that you have a lot of sports medicine guys, really 3 or 4 of us now who are available at any time and you can bring them in. And so some people don't have that luxury. If you're up in way up north or whatever, it may be harder to get them in, but pretty much everybody can get in. And I think if any doubt about it, you can always refer them and we're always glad to see them. Prepping for play, I think we're all understanding now the more of the dynamic work, getting warmed up, doing hamstring stretches and saying, let's go is not what you want to do. So you want to go through these movement type activities. And I think this is a key one down here too. Preparing for an upcoming season can't start one day before the season begins. And we have a lot of that in our high school kids, especially, kids. Track is one of those things that people go, I think I'll run track this year and it starts tomorrow. And I think I'll do the 2 miles. Okay, well, good luck with that. And it's 88 degrees, so this whole thing is a problem, but, and these kids end up weeding themselves out because they can't do it. But, trying to get that preseason program and trying to think about it in the non-big sports, girls soccer, that's a big sport. They're organized. They got it figured out probably. Football, it's probably got it figured out. But, there are all those other sports that just don't, and particularly track, baseball is very lackadaisical. And so you just want to see if you can instill preseason workouts or some kind of fitness, with your athletes so that when their season comes up, you've seen them, they've been working out and they've been doing that for whatever period of time. And that's balanced with, they played football, they played basketball, and now they're going to play baseball. So I like the cross training part of it, but it's still, they need to be prepared for the baseball part. So, and this is the cross training thing too, is that I do think that there's a lot of refreshing things here. I have kids that tennis players that will come in and a lot of shoulder problems, 16 years old, hey, have you ever, taken any time off? And the answer is, yeah, we didn't play in a tournament last weekend, and it's kind of like, yeah, that is time off. But we were thinking maybe you take 2 months off or you take 3 months off. So that's really where the resting period is. And I can say to almost every player, when you can convince them, because they're convinced by not going to that tournament, they will lose. They're going to get out of sync. Everybody else is going. If we don't go, we're not going to make it. But I think to the person, the ones that get injured, when you can convince them to take a 2-3 month hiatus, do something different, when they come back, they're more refreshed, they're actually better at it, and they have more energy to do it. I don't think I've ever seen somebody that I said, oh yeah, well, you took the 3 months off, so you're not going to be able to keep up with the other ones. They across the board do it. It's mentally, it's almost impossible for them to feel that way though, because all the other kids are going to the tournament games, all the other kids are doing the other thing. So and so I think the other part is that, I don't need you to quit playing tennis and not do anything. I just need you to go play soccer. I need you to go do something else that emphasizes a different skill, a different exercise group, because I think those things give them a better fitness. When you're tennis, is a very specific thing you're doing. When you're soccer, that's very different, or whatever that is. So I really think it's important to kind of teach them how to rest certain joints and make other ones work. And then I think their attention span and their mental part of it, having that break. It is possible to be in 11th grade and get burned out. And so a lot of these kids happen to that because they've been playing since they were 3. And they're there. And I see that, when I talked about that slide of lack of interest. And that's what I see. I see these kids that are on the basketball team. They've been playing since they're 3 and their ankle is injured and there's not much going on. But this kid is disinterested. It's like, well, we can get you back to practice. No, it's okay. That's okay. And that's what you want to try and avoid. And that becomes that parent dynamic because the dad's the coach and he's just kind of wondering, why aren't you letting her play? And that whole thing. And we've all seen that and been through that. Contusions it's kind of really a variation on strains and overuse. A contusion just means you kind of know what happened. They got whacked on their arm or they fell on it or did whatever. But it's still, sprains and overuses and contusions are all going to kind of be in that same category. How long is the pain? How do they, not so interested the day of the injury, but tell me tomorrow how it's feeling, because if it's all gone by tomorrow, we're not too worried about it. They're not gonna have a broken arm. It'd be great the next day. But if they are, then this is where you have to think about it. But we're all gonna get into the same thing, right? We're gonna use RICE, rest, ice, compression, elevation. That is pertinent. And I tell people in my office all the time, this is what we need to do. And it's gonna be amenable for you. And the contusions are just gonna fall into the treatment of sprains and overuses. Is there a reason? Did you overdo it? Or what could be happening? Fractures I was gonna talk about, because I think that these are legit things that we get. And sometimes when when you hear the snap of the bone and the leg is crooked, there's not much doubt what needs to happen there. They need to be splinted, you need an ambulance, you need to go to the hospital, and that needs to be taken care of. But there are a lot of other subtle things that can happen, maybe not so subtle, but you can have a broken collarbone, so you can get this bone right here that is supposed to be attached to that, and there's one piece and two pieces and three pieces and four pieces. So this is a 4-part clavicle fracture from a kid getting tackled. And and I always, and this kind of thing is they're hurting and they're in that and they have this problem. And so here's another example of it, maybe not quite as bad, but still a 3-part clavicle fracture. And then here's a fracture of a proximal humerus. So right here, so broken across there. Again, these are football, all 3 of these are football injuries. And so you get this injury right here. And back, when you have these fractures, there's a lot of screaming and things that can go on and hurting. And there was back when I was initially started my training, there was a book that was written, it was called The Intern. And so if you were an intern, you read the book, The Intern, back in the day, because it talked about the life. And it was kind of like this glorified life of an intern and what it was. And one of the things it said is that when you're being called to go to a cardiac arrest, what's the first thing you're supposed to do? And the answer is take your own pulse, because you have got to be the person that's calm. If you go in there all frantic-y, then everybody's frantic. That's a big thing I like to instill on you guys, is that nobody else has more knowledge about medicine than you do on the football field. And when you are screaming because everybody else is screaming, then it's complete bedlam. So you have to be in control of it. And I think part of that is if you're a rookie and never done it before, it's probably hard to do it. But once you've been in it longer, you can do it. And so I would contend that these fractures and stuff can be managed very easily by you in the training room, to start with. So the panic of, they have a collarbone fracture, we got to send them to the ambulance. Okay, so let's think about that. So they're there, they're going to go with the ambulance, and they're going to get to the ER, and they're going to take an x-ray, and they're going to go, yeah, you have a collarbone fracture, or you have this proximal humeral fracture. And what we'd like to do is we're going to give you this sling, and we'd like for you to use ice. And then we're going to have you see the orthopedic surgeon on Monday. And that's 4.5 hours later and $3,000 later. And so I think that why would you send them? Well, if you have a pain management issue, if they're screaming bloody murder in your training room, you can't send them home to mom. They can't. But many of these, by the time they've gotten off the field, you finally figured out how to get their shoulder pads off, and you've examined them and you go, I can feel a little bump there. They're okay. They're hanging in there doing all right. And so I would just contend that, they are going to need attention. That doesn't need surgery, but that does. Okay. But that surgery doesn't happen Saturday, Friday night. That surgery is going to happen probably a week later. And so I would instill in you to say, take charge of that situation. But if you tell them, oh my God, it's a broken collarbone and I don't know what we're going to do, whatever, then you're going to the ER, because now they're there too. But if you're calm and you can say, yeah, you know what? I've done this before. It's a clavicle fracture. Probably not going to need surgery, maybe, but nothing's happening this weekend. So let's just do treatment, see how it goes. And if you can manage it, I just think I would challenge you to say, I think I can do this, with these kind of fractures and be okay with it and manage it. And I think that's well within your realm of doing that. I think similar in ankle fractures, I think if the foot is turned backwards, that's a no-go. That can't happen. But many of these little distal fibular fractures or proximal fibular fractures or any syndesmotic injuries, so they have a sprain of that thing, might require surgery. Absolutely. But Bob Anderson's not going to do that fracture until next week. And that's desirable. It's actually not desirable to do their surgery the day it happens. Usually we let the swelling go down and let the inflammation go down. And so you're doing them a favor by controlling them, taking care of them. So that's kind of my whole discussion on fractures. I think I feel like I see so many kids that have metacarpal fractures, phalangeal fractures, distal radius, non-displaced fractures, and they have 3 x-rays from the ER. You know, they're worn out because they drove from wherever to whatever to get this done. And I think, wow, what a waste of time that was. And I said, what did they do in the ER? They said, come see you. Yeah, I know. So you can do them a favor by kind of working through that.
Dr. Spears, real quick, on that one that you had, the 4-part clavicle fracture.
Yep.
So that is something, I mean, that could wait, that would be something you wait.
It's a pain management issue. It's a pain management. If you can't control their pain, then yeah, you can't prescribe them narcotics.
Right.
And they potentially would need narcotics for that.
Okay.
But if it's not a narcotic thing and they're comfortable, there's nothing that's gonna be done in the ER.
Sure, right,
You know,
right.
so I think it absolutely can be managed.
I mean, that'd be one of the conversations we may get a phone call from a parent going,
Yeah, they have a collarbone fracture, what's the plan? Well, we have a Dr. Spears who can see them Monday morning at 8 o'clock, and we've already set up that appointment for them. And that's really gonna go.
Going with the same fracture here, how would you position that if they go into the ER? Are they going to butterfly that? Or are
No,
they
well,
just gonna-
not really anymore. I mean, that's kind of, the whole figure of 8 has kind of gone away. Either it's lined up well enough and it's okay, or you fix it. And I'd say the fixing has more to do with the number of pieces and parts here. So these 4-part fractures have a high rate of non-union. And so these typically are going to have plates and screws put on them. And actually, even though I showed this one, if you didn't have that 3rd piece right here, even though that's displaced, that in a 15-year-old probably heals perfectly. And so you would probably not put them through the surgery for that. But when you get this comminution, this extra piece, it just means that the blood supply is more disrupted, and that's really what it's all about. When you look at a collarbone fracture, what you don't realize in kids is that they have an incredibly thick lining around their clavicle, which is their periosteum. So the periosteum is providing this blood supply. When the bone breaks and goes up like this, usually that periosteum is still attached. It gets stripped off of this bone, and it gets stripped off of this bone, but the pouch around the 2 bones is still there. So all the nutrients and everything are still in there. There's still wonderful blood supply. And that whole hematoma inside that periosteal sleeve will become bone. So when they have 4 parts, the periosteal sleeve becomes disrupted. And so now the stuff's leaking out, and the blood and the periosteum is flipped up over here. So there is no healing nutrient there. And so the mid-shaft clavicle fracture where the periosteum is disrupted now becomes a liability. That you're better off putting it perfectly bone to bone for it to heal. But those, I think those are the things not to worry about. The things are, you can manage these things and save them a lot of trouble, but you just have to be confident. Because if you're not confident, then it will exude out to the parents like, okay, we're going to the ER. Because nobody here really knows what's going on. So just, those kind of things are important. The other thing I was going to talk about in this same realm is the AC separation. So that's kind of the same thing. And when they pick up the quarterback and dump it on his shoulder, either you can break his collarbone or you can separate his shoulder. So you get this little collarbone sticking up right here, and there are variation on it, but you can see what happens. So instead of the bone getting broken here, they dislocate from here. So there are ligaments that go from the collarbone down to the coracoclavicular ligaments. There's also an acromioclavicular ligament. And in this case, this is a grade 3, actually a grade 4, because it's even higher than the grade 3. There's pretty much complete disruption of those ligaments. So again, what are we going to do on Friday night? Nothing. We're going to manage it. So I do think these kids need to be splinted. They need to have a sling, and sometimes a sling and a swath, so something around it to hold it are appropriate. You got to ice them down. Tylenol and a leaf are great for you to do. And if they're comfortable with that and they can make it, they're good to go. If they can't, then they can always go to the ER, but I'm just telling you, I know what they get when they go there. The ER has no interest in discussing what they're going to do for this AC separation. They have no clue what to do for it actually. And usually they get the wrong x-rays. So we're always stuck with, in our office, x-rays that mean nothing to us and we're trying to repeat them. And so it really is not that helpful, but sometimes it's a necessary evil that they have to go because you just can't manage them. And sometimes there's a parent freak out that will not be satisfied until they go to the ER and then it kind of gets under control. But usually they're upset because they didn't do anything for them. Why'd you send me here? They didn't do anything. I know. But-
What is the right x-ray? Is when you said the wrong x-ray, now I'm curious, what is the right?
Well,
X-ray?
normally they'll do it very oblique, so the kid is like this, okay? And so if you take an x-ray like that, then the arm is all, then I'm looking at the shoulder. Dislocation's coming. It's coming up in just a second. So the kid has the shoulder, and so we want this AP view just like this, so we can see this right here. But all of a sudden, the kid is turned like this, and so this is the view we get. And so we can see it's broken, but those aren't the views that we really want. And so our X-ray people are just more trained to say, get them to relax, turn their body, get it lined up, as opposed to a shoulder picture, that's whatever you can get. And then that's true with that. It's true with knees, kids that have, when they're hurting, they're not good at positioning themselves on an X-ray table. And basically the X-ray people at the hospital at 3 o'clock in the morning are just trying to get them through the whole process. So we just get a better detail, better evaluation, so it just helps us not repeat X-rays that don't need to be repeated. So not to get too much of the weeds here, but these are kind of the AC separation things we're talking about. You can see the collarbone gets separated. Here's that, the grade 3 up in here. This is kind of the grade 4 where it actually goes up higher. Again, not so important to talk about, but a common thing. AC separations are not uncommon. And you want to differentiate those words. This is not a dislocation, right? A dislocation we'll talk about is the glenohumeral joint moving in and out. This is an AC separation. It's this part separated from here, and these ligaments are torn, and those ligaments are torn. And these kind of have the same process as clavicle fractures. Badly displaced ones tend to need surgery because they're unstable. Grade 2s and 3s usually don't. Every hockey player I take care of has bilateral AC separation. As they get into the boards, the collarbones stick up, and we don't do a thing about it because if you fix it, the next year they run into the boards and they stick it back up again. And so, but they have these big collarbones that stick up and they do incredibly well. So it's amazing how well that can do and how bad it can look. And I tell them, look, we can fix this at some point, but it might heal. And really that's what's important. It isn't important that the collarbone be brought down here. It's important that these two things move together. If when they raise their arm up, their collarbone is moving, that instability leads to being unable to lift, to be able to throw. That is a painful, achy problem, and you have to stabilize that. But if it heals together, so this ligament heals, even though it heals out of position, because it will not come back into position. So you got to tell them it's going to be like this forever. But if it heals, their pain will go away and they can play hockey and do all these things. If at some point they don't like that, then you can always go in and take the bump off. If it's a bump issue, that some people don't like that bump on their shoulder, you can always take that bump down and get rid of it and not have to do a reconstruction or repair of their ligaments from the get-go. So separations, clavicle fracture are kind of in that same role right there. Rotator cuff injuries, I just put that on there. This is something you'll never see. You're just not going to have rotator cuff injuries as kids in high school. This is going to be, you got to be old like me and Dick, and we get these kind of things. So, and actually 40s and stuff. And my youngest rotator cuff injury was a 16-year-old quarterback that hurt his shoulder, but that's the only kid I can even remember in my 30 years that had this. So it's not really that big of an issue, but I bring it up because you hear about it, and really the rotator cuff is the muscle part of this, right? So this is our right shoulder like this. And so we have our scapula here. Here's our clavicle, the ball that dislocated would be right in here. And the rotator cuff, what? Oh, am I? All right.
We'll figure it out.
Okay. I know we're past pitch counts for sure. So, so the rotator cuff is this muscle here on top, supraspinatus, infraspinatus, teres minor, and subscapularis. So they all come off the scapula and they go across and hold that ball in place. And so that, where we talked about bone injuries, ligament injuries, that would be a tendon or muscle injury. And usually the deal is that, well, what happens? Well, if you're 50 and you get dumped on the ground like a quarterback gets tackled, you tear your rotator cuff. When you're 16, you break the bone. So it's where's your weakest area? And in a 16-year-old, that rotator cuff is tough as nails. It's very hard to tear it, but they can break the bone. So anyway, so for rotator cuffs, not too big a deal. Here's an example, I don't know if you can tell, but this is an MRI. This is a normal. So this is your supraspinatus muscle right here. It's coming across, it goes around and it attaches right here on that bone. And here you can see a torn one. So here's the muscle and there's the end of the tendon. So that's been torn and it's spring-like, right? It's got flex to it. So when it tears, it goes from here and it jumps all the way back to there. So this is kind of thing that we fix. We do a lot of these kind of things and that's what it looks like. But just so you know what rotator cuff is, that's really all we're going to talk about it. Nerve injuries, another big problem, burners and stingers. And, this is kind of the anatomy of that. We got this brachial plexus, so our head's up here, our neck is here. This brachial plexus comes underneath the clavicle, goes between that and the scapula. These all going down. This is going to our thumb. This one's going to our little pinky. They're going all the way down our arm. But when we take and stretch, we can have injuries. Now, when we have this one nerve right here, the axillary nerve, you can see how it's interesting how it goes underneath and goes underneath this part and comes around. That's what supplies our deltoid muscle. So when you hear about a dislocation, which we're going to talk about here in just a second, this ball coming out, you can see how it can nail that nerve right there. So if this goes out, that's the anatomical problem. And so the axillary nerve injury associated with dislocation is a really important thing, and that's the anatomical part. Now, I was really thinking here more about the burners and stingers, and really what you get into is more of, this is a picture of deltoid atrophy. So if the C5 nerve root has been injured, you can see that muscle is missing right here where it goes away. And kind of what you get is this kind of a mechanism. The head gets pushed to the side or the shoulder gets pushed down or some combination of that. The nerve roots come out here. And so all the train tracks come together and merge in the brachial plexus. And then when they go past the arm, they divide up into their pathways. And so you can get these kind of things. So here's where the traction injuries can occur. And again, I think the key to this is that most of these kids do very well. So they come out, they have numbs tingling down their arm, the burner, the stinger, whatever it is. I was at the combine last week. I have a kid that I saw at the combine, All-American player, had a burner in a game, missed 4 weeks because he was unable to raise his arm. They decided that it was the last game of the season in the playoffs for the conference, Southwest Conference Championship, or Big 12, I guess it's called now. And he felt like he was pretty good, played again, re-injured it during the game. So we are now 3 months out. He still is unable to raise his arm up. So it's a good kid, and he's got this C5 nerve root injury. So I think the important recognizing them, how many have they had? If it's their 10th stinger, there's something wrong going on. If they've had one stinger and it lasts for a few minutes, great. They have to have 100% normal strength to go back into play. If they do not have normal strength, they are at risk of injuring this nerve and potentially having permanent injury. I mean, I suspect this kid has permanent problem with this, that he'll never get full recovery of it. And he might be able to play still, but it's that kind of seriousness. And so the anatomy is this, of how it happens. And your thing is to say, and again, if they can't play that game, that's fine. Then they need the next day. The next day you need to say, all right, what's going on now? And if they don't have recovery, the next day, they're probably going to be several weeks before they're ready. So it usually it's I'm okay right away, or they're going to take time. And if it takes time, you need to let the coaching staff know that this kid's going to be out. And I would say too, that for a burner stinger that happened Friday and by Monday, there's not been recovery, it probably should be looked at. You got to make sure they don't have a herniated disc. You got to make sure, again, there's not much that would be done other than getting an x-ray. They could have a fracture. That would be possible that they did, and you don't know it. And so I think that needs to be looked into for burners and stinger type injuries. This is another one. This is wing scapula. So see how this kid's scapula is sticking up? So this is a long thoracic nerve injury. Again, I bring it up because it's one of those things you might see. You know, it's not uncommon. Again, it's a traction injury here. The long thoracic nerve is one of the distal branches off the brachial plexus, and it goes to the serratus anterior, which is actually more in the front of the rib cage, but it's the inability to pin that scapula back down. So you see how his scapula is pinned down. And so you see it, I tell him to do a push up on the wall and the scapula sticks out. And again, these are played with more often because this will take a year to recover if it does recover. And it's not as critical in that these are typically not nerve-driven problems. The long thoracic nerve is a peripheral nerve. And so I've had some kids with this that we have had them play. In fact, they've been playing and they come in and wondering what it is. So just another one, wing scapula, long thoracic nerve injury from the brachial plexus. Not as critical as a cervical root type problem or brachial plexus injury. Tumors and growth, I only bring this up, you'll never see one of these, but we went up to Iron Mountain and go up there. We have a kid comes in, he was working out in the gym, kind of slipped and fell. Hurt his clavicle, and he came in and he had this fracture right here of his clavicle, broke right across this right here. And we thought, well, that's strange, but what is this little thing right here? When we saw this x-ray, we thought, well, I wonder what that is right there. And so we kind of looked at it and we said, yeah, it's broken. And what did you do? Well, I was just kind of lifting weights and doing stuff. So we kind of didn't get tackled playing football, kind of a minor injury. So we became concerned about it. And so we did an MRI. And when we did the MRI, we saw this huge tumor sitting right here under his clavicle. And so there's that tumor. So this is the soft tissue part that started inside that bone. So actually, this is a very low-grade osteogenic sarcoma. And so it was picked up in the Bellin Clinic the day after he heard it with this. We actually sent him to Milwaukee, and he had a full resection of this done. He had the bone plated, bone grafted. He's actually done great. This is him the night of surgery. So all he wanted was 2 meals, was the main thing he wanted, but had that clavicle fracture. So he had a clavicle fracture associated with it. So I really have never even seen an osteogenic sarcoma before in a clavicle. So I think they're incredibly rare, but just to say they're out there. That kind of stuff happens, and you just have to have, again, what would happen with this kid? He got hurt on Thursday, but by Monday he was not better. He was still hurting, still a problem. That should just go off as, okay, that doesn't make sense. And then he gets in, gets quick treatment. I mean, it probably saved his life that it broke, because otherwise these become high grade, become very, they transmissible, go to your lungs, your brain, and it can be a real problem. And this is probably 2 or 3 years ago now. So he actually played his high school career and he did really well. So labral tears is kind of my main focus I wanted to talk about, because I think this is what you guys see and what we operate on. You know, so we do a ton of we see a lot of shoulder problems and we see some fractures and things, but what I operate on are these labral problems. And so when we talk about a labrum, we kind of look at this. So this looks good, it's going to be pretty good, but in a second, something else is going to happen is he's going to hit the ground. And when we hit the ground and we leverage this arm, some bad things can happen. We have other examples of this is going to be a bad thing, and that's going to be a really bad thing. And so what happens here is that, you know, this is a picture of an acromion, and you can see that the humerus is sitting way down here. And what happens with these is that you get this picture, which is normal, and here's the dislocation right here. So if we think about how this shoulder works, probably better to do it this way. This is our socket, and so the socket is quite small. And in fact, if we think about this, when you look at it, here's our socket right here, and the ball is going to be in there, so the ball is missing now. And depending on which way you go, you can have injuries. The big part of this is the anatomy of it. If you think about it, this is a really dumb design. We have this really little teeny socket and this huge ball, and we're trying to hold them together. Now, if you want to look at a good joint, look at the hip. Get that big old socket, the ball goes up in there. It's incredibly stable, but try and throw a baseball with your leg. becomes a real problem. So we've adapted to this little teeny socket and this really huge ball. And so it's akin to this, you know, we got a little T with this big ball on there, and balancing that and holding it becomes very difficult. And the way we do it is we have a labrum that have ligaments attached to it, and we have a rotator cuff. So those things are sucking on that ball and pulling it into the socket as hard as they can at all times. And so you can have injury to your rotator cuff, but like I said, the rotator cuff in the high school age group is pretty bulletproof. You're probably not gonna have trouble with it. But where they get into trouble is that there's a point where my arm will not go very far past this. And if somebody forcefully makes it go further, then something has to give. And so in the front of the shoulder, we have a ligament in the back of the shoulder. So depending on how this ball goes and how it leverages, if it goes out, then for it to go out, the ligament that's attached to that bone has to separate away. And when that separation occurs, then there's an opening there. And if you're the first doctor to name it, you get to call it after yourself. So Dr. Bankart did that back in 1890. So he described the very first time that when this ball goes out, this ligament will tear off of the bone, and now it sits over here. And the problem with that is that then the ball either is put back into the ER, or you put it in on the field, or it pops back in on its own. If that ligament then doesn't heal back to this bone, there's a gap in there. And every time they pick the arm up and that ball peeks over the edge, it wants to slip in that little hole. And so they could dislocate again, but a lot of times they just feel like it's going to dislocate. So the apprehensive feeling is a big deal. And if they, instead of diving like this or having the arm brought back behind them, but they were blocking somebody or they're running and they get hit, then the ball might go out the back. And it's exactly the same thing. So it's a reverse Bankart lesion, but it's still the ligament and the labrum that are torn off. And again, labrum is so in the parking lot, when you have the little thing that your car goes up to and you bump or it goes into it, the labrum is the bumper of the shoulder. So it creates, so these ligaments are coming in, they're very thin. How do they attach to that bone? They attach through the labrum. So the labrum is this round binding bumper that deepens the socket because it's little already, so it deepens it some, and the ligaments attach into it. So in general, when we say labral repair, that is what we're fixing because that's what tore off, but we're doing it because we're fixing the ligament, because the ligament attaches to the labrum that goes to the bone. And so we'll show a video of how we do that. And so on the face of the clock, we think, you know, there's a front, a back. And so if we think about going from 2 o'clock to 6 o'clock would be anterior, from 6 o'clock to 10 o'clock would be posterior. But then we got what's 10 to 2, you know, what's up here on top? Well, 10 to 2 is where we talk about SLAP lesions. So SLAP, which means superior labrum, anterior, posterior, that's the acronym. And what it has to do though is that it's very hard to dislocate your shoulder up, right? There's nowhere to go up. So if you look here's the ball and socket, here's this, it's hard to go up because there's a bone right there. So what SLAP lesions have to do with, they have to do with your biceps tendon. And so when the biceps is rotating and twisting in your arm, it's torquing and putting pressure on this here. So just from an anatomical standpoint, we have anterior Bankart, posterior Bankart, and SLAP. And so we talk about those three things that can get injured. So I think I have some pictures here. So this is more of the SLAP tear now, that when you rotate your arm, you get this tear right up in here. This is the biceps tendon. And why does that happen? Well, because of this. So we get this arm that becomes this crazy position that you have to have. And so as that ball rotates, and I really can't show it here, but well, maybe we can. But as this, you can see the biceps tendon right here is in the bicipital groove. So it is fixed in that groove. When you take your arm, it already has an arm. When you take your arm and you rotate it, you are pulling back on that biceps tendon. So people talk about this being a peel back mechanism. So the biceps is attached on the glenoid, right at the very top, on the superior labrum, right? Superior labrum. And when you torque this over and pull it, then you peel back that. So SLAP lesions are related to overhead throwing activities. They are not traumatic. You cannot get a slap lesion by being tackled. It's impossible. Those are all going to be anterior Bankart or posterior Bankart instabilities, and slap tears are going to be cocking injuries with throwing. And it doesn't have to be that, but look at this professional baseball pitcher. Look at where that arm is. And imagine the amount of torque that is applied to the biceps tendon because it's rotated way back and then it's going to accelerate forward. And so again, this is just kind of showing that mechanism. There's the biceps tendon in the groove. And when you rotate backwards, you can see how the biceps is way back here now. And it's putting pressure right there and it can tear this just like that right there. So we make a joke about GERD. So we like GERD in our clinic. So when you get a slap tear and you get a lot of, and we already know it's external rotation, part of that can be is that when you get a slap tear, then you lose the stability of the biceps. It actually now will go too far backwards because the biceps was holding, but then it tears or it stretches. So when that ball goes back and it's rotating backwards, the rotator cuff is attaching in here. And when it rotates, that back rotator cuff can actually hit into the posterior labrum. So we call that internal impingement. So it's inside the joint. So it's the impinging of the rotator cuff against the glenoid. And when that happens, they can get labral tearing, fraying. So different than the Bankart, because the Bankart is a dislocation instability. But if they load it up and they tear this labrum, they can also injure their rotator cuff. And it's a constant hitting of that rotator cuff that breaks it down. And the natural thing for them is it breaks down and they heal it. They break down and they heal it. Well, when the posterior rotator cuff, and in particular, this would be the infraspinatus, okay, that's the one that's there, it gets tighter and tighter and tighter. And then what you find is that when you test them in this, what we call sleeper stretch, they're unable to put their hand flat on the table. And so because they've got a contracture of their infraspinatus from cocking and loading because they destabilize their bicep tendon, they may or may not have a slap lesion, but they break it down, they heal it. They break it down and heal it, and 5 years later, they get this. So in early phases, so this is a really critical exam. If you've got a thrower or a hitter and they're having shoulder pain and you're rehabbing and you can't get them better, check their sleeper stretch. Because if they're tight, and it's really critical that you see this guy is 90 degrees to the table, and that has to be 90 degrees out. It can't be up here. It can't be here. It has to be 90 degrees up like this, and you're testing them like that. Because otherwise, they can, you know, if they lean back, they can put their hand down. When you tighten them up like this is when they can't do it. So we spend a ton of time with our throwers doing this sleeper stretch and talking about loosening it up, because almost all of them have done lightweight, high repetition exercises. They've done ice, they've done everything. But then when you test them, sometimes their arm is just going right here. And you can sometimes stretch them. And we do this sleeper stretch. We just get them to stretch every single day, a couple times a day. And if it's early on, it'll loosen up and they can do great. Other times we actually go in and have to release the infraspinatus tendon. They have a labral tear, we'll debride the labral tear. And then they can do fine with it. And then you have to kind of work on these mechanics of not letting that happen again. So that's kind of a bunch of things. Anterior dislocation, posterior dislocation, labral tear. Slap lesion is across the top with the peel back mechanism injuring it. And then internal impingement, which is more of a cocking phase related to slap tear, infraspinatus injury, and glenohumeral internal rotation deficit. So GERD is a big word that we use because we see a ton of this kind of stuff. So what do you do about it all? You know, kind of the old stuff, right? Ice and heat, you know, medications. I'm not big on a lot of medicines in high school kids, but I think Aleve and stuff every once in a while just doesn't hurt a thing. And sometimes it does get them through seasons and to a next game or whatever. But again, you've done your evaluation. You don't think it's serious. You know, they're not, you know, you don't want to give them Aleve and let them play because they're worse Tuesday than they were Sunday. You know, that's probably the wrong thing to do. And then, you know, getting physical therapy, but maybe that therapy is done in the training room, you know, trying to exercise it. Injections probably don't have really any role in this kids. I guess I do them sometimes diagnostically. If I'm trying to sort out maybe if somebody has an AC joint problem or a labral problem, you might do it, but it's incredibly rare. It's incredibly rare that we would do that. So what do we need to figure it out? A lot of times, I feel like when I see these kids do our physical exam, I feel like I know what's wrong with them before we do any other testing. Usually you can look at them, what happened to you, because you already know, right? If they dove for a ball and the shoulder dislocated, they don't have a slap tear, right? They probably don't have a clavicle fracture. They're going to have a labral injury. And now the question is, how significant is it? How long have they had the problem? What are you going to do? So we feel like we already know what's wrong with them before we do any of these things. But we typically, you got to get x-rays, you got to make sure they don't have a fracture. And MRIs kind of become the standard of looking inside the shoulder. Sometimes with an MRI, we also need to do dye. We need to put dye inside the shoulder because as strong as the MRI is, frequently these labral tears are torn, but they're sitting right up against the bone when you do the MRI, so it looks okay. But when you stress them, the ligament comes apart. So putting dye in there opens up the space between it so you can see it. And sometimes you just can't see it without the dye. So arthroscopic surgery, kind of normal anatomy. This is where I need to get it to start.
Is it just right here on the screen?
I think it's, yeah, there it is, that little play button. So go ahead and pause just for a second. So shoulder arthroscopy. I don't know if you guys have seen it before. This is what we get to see. So when I do my job every day, I'm playing a video game all day. I got a camera, I've got instruments I work, I'm looking at a TV screen inside the shoulder. To position the patient, we position them on their side. So this is a collarbone like this. We turn patients on their side and do them lateral decubitus. So you are looking at the shoulder like this, okay? And so the socket is going to be this way, and the ball is going to be this way, and the arm is going way down there. And then this would be their biceps tendon. So go ahead. So I think anatomy in the shoulder is really, really hard to follow. I think people struggle with, they're in there and they're like, oh, where are we going? But you can see the instrument I can use in here. This is our little shaving tool. And I can actually take it to lever up the ball. So you see I can lift it up. And there's our labrum. See this labrum right here? So that's what we want to see. This is the humeral head right here. And again, this is our little device that it actually shaves, it cuts, it burrs. We have a lot of things with it. Here's our biceps tendon. You can see how clearly we can see that. And I'm going to move that around. This is the rotator cuff. And so this is the normal. This is what you want to see. You want to see the rotator cuff looking normal. Here's the biceps tendon. And if you had a slap tear, it would be right here. So we're looking for that. We can pull the biceps down into the joint. It has a lot of flexibility and mobility. And so we can see the ligaments. We can see all this. Again, there's the labrum, humeral head, rotator cuff back here. So you can see how you really have a really expansive view all the way around right here. All right, so we can go to the next one. And then I was just going to show you just so you can see kind of some stuff. So we just saw the normal one. Okay, so look at this now. So this rotator cuff, and I know this isn't pertinent today, this rotator cuff is now torn. So this is the difference. There's that biceps tendon, there's the ball, here's the socket, here's that rotator cuff that was all nice and flat, now looking like this. And so we take that little debrider I had, and now we get rid of all that. And right here, we start to see some little opening right there. And that's what these rotator cuff tears look like. And when you go to the other side of it, here's the torn edge of the tendon. There's one little piece that was trying to heal, but here's the bone. This tendon is supposed to be up here, and I think I have a picture doing that. So here I grabbed it with this little tool, and I took that tendon and put it up here. So what we can do is we can take this little anchoring device. So you can see it looks like a drywall anchor. The bone is very much the quality of wood. You can drill it, you can tap it, you can put stuff in it. So this little anchor right here then gets screwed in, and on that anchor are attached two sutures, and there's sometimes what we call labral tapes or suture tapes. And then when we put that in there, we can then pass that through the tendon. So if this is the bone and this is the tendon and it's here, we drill those anchors into here. There are sutures that come out. We have a device that passes them through the tendon, and when we tie the knot, it brings the tendon back to that bone. So right here, we're in the process of tying this knot. We already tied this one, and so that's binding it down. This knot's being tied right here. We already tied one right there. And then when we get done, it kind of looks more like this. So there's these sutures, and now this edge of this tendon that was sitting back here is now up here where it's supposed to be. And this is kind of the construct, and we're overachievers. We put anchors here, which is the belt. Then we put no anchor here. These are the suspenders. And then we get 2 more anchors here, and that's another belt. So we have 3 layers really when we do rotator cuff, 3 different layers of failure potentially for this to give away. And so that's what this construct is. And you see how they crisscross and hold this torn edge right here in place. So that's rotator cuff. A lot of that's older people. Your kids aren't going to have that. So this is a labral repair. And again, this is a kid dislocated multiple times, like 5 or 6 times, unstable. And so his labrum is torn, but remember that means that the ligament that goes with it is torn. And so this video is going to show, this video is going to show us drilling the hole and putting these anchors in and having these sutures going through it to repair. So here's the gap, right? This was all torn all the way down, and now we're moving it back to where it's supposed to be. Go ahead. So
Anterior anchor, right?
this is anterior, yeah. So scope is in the back of the shoulder. We're looking to the front. Here's the humeral head. And in this kid's case, he completely tore his labrum off. So see this piece floating around here? So the labrum's pretty big though. So we decided not to incorporate this into the repair. Go ahead. Oh, it's going already. And so we removed this part of the labrum because there was the other half of the labrum still there, and that's what we utilized for the repair. Remember, you got to have something to bite into. The ligament is teeny. It's not strong. You need that labrum to grab onto. Go ahead. So here it is, and we're going to bring in our little tool. So there's our little muncher. So it likes to chomp a lot. And so we're going to get that out because this labrum is just going to be unstable. You're not going to be able to do anything with it. And we need to clear that opening so we can see what we're going to do. And so again, humeral head. This is the glenoid. Right here is the edge of the glenoid. In just a second, I'm going to show you the labrum that's going to be sitting separate from it. Okay, go ahead. And so this is kind of back to that original video. I'm making sure his biceps tendon looks okay. I mean, he's got a dislocating shoulder, and here's the labrum right there that's going to be separated. Go ahead. Okay, so let me set this up. Go ahead and pause there for a second. So, yeah, a little bit. There you go. Here, so I have now moved my camera into the front of the shoulder, so I'm looking straight down at it. Here's the edge of the glenoid. And there's the labrum, okay? There's a huge cavern right here. This is Grand Canyon right here. And you can see my shaving device is going in here. So what we do is we're gonna make this shoulder very angry because we want that bone to be bleeding and to be angry about it. So when that labrum comes back to it, it goes, oh, yeah, you're supposed to be attached here. So we wanna mimic what happened. When he dislocated, he ripped it off, it bled like crazy. But that was 3 months ago. So now it's all kind of healed in and it thinks it's all good to go. We're going to say, nope, we're going to take this shaving device. We're going to burr all this bone. And look at this labrum. This is a huge labral tear. It starts here. This is probably the 2 o'clock position. And we're going to go 3 o'clock here, 4 o'clock, 5 o'clock, and he's torn all the way to the 6 o'clock position. So this labrum, this whole thing is the labrum, and back behind it is where the ligament's attached. Okay? All right, go ahead. So as we take this shaving device, you can see here, so you see how I can pull the labrum away. There's the bone. He actually has a small fracture right here too, where that little piece of bone is broken right there. But we're taking this device and we're opening that up to create this space. So we make that bleeding. So here we are shaving it, trying to make it mad. There's the, whoops, gosh. All right, that's okay. So now that we've cleaned that up, we've now put sutures through the labrum. And so how do we make it stay there? Shoot. Actually, I think it will start when I do it. This is now the labrum. This is a little drill guide. We're getting ready to drill a hole into this bone. We're going to put that little screw in thing. This happens to be one that doesn't screw in. It actually has reverse barbs on it. So when it goes in, it catches and it gets deeper and deeper, it gets tighter and tighter. And then we're gonna tighten that ligament up in there. So I'll show you how we do that. So drill guide, here it comes in, start drilling. It cores the bone out. So that comes out. So now here's our labrum. We've already passed these sutures. This is the little anchoring device right here that holds the sutures. We're gonna drive that into this hole all the way in, and then this reverse barb is gonna go fixate that into position. So we use a little thing called a hammer. And we tap that down in there and we bury it to the line so we know it's fully in there. And now you can see that these sutures are attached to this labrum right here, and it's back up against the bone. And then we have a little arthroscopic scissor that comes in, and you can still see we still have work to do here. This is still gapped open right here. That labrum has got to go here. And so you can go in there with this very nimble scissor. It cuts the sutures, and there's our first point of attachment of that labrum. So we do a similar thing. In this case now, we've now, you can see how we're passing the sutures through. So we've got them in. We actually have a device that bites through it and passes the suture. And then so you can see that this suture is now in that labrum. So this is still not attached. This is attached here. We grab the sutures and bring them out through this hole, kind of showing a little more of the steps here. Now these sutures are in, but they got to be in the bone. So come in with our guide. And really how many of these you do depends upon the size, how much stability it has, but you can now see this is that labrum right up in here. There's the ligament behind it that have now come up here. So we now got another drill hole into the bone. This is the suture tape we put in. This is the device that holds those sutures to drive them down in there. You can see there's a little fracture that actually happened in this kid's case that was buried in that. So we're creating a little more space with the suture. We drive it in, and now that labrum is attached to the bone, and then the little white anchor is right here behind it, and it drives in. The suture is a permanent suture. It will always be there their whole lives. The anchors are actually incredible now. They're made of a biocomposite material that actually over a 2 or 3 year period of time turns into bone. So the actual anchor does actually disappear with time and become bone. Back 10 years ago, all of our sutures, all of our anchors were biodegradable, and they would dissolve, but they caused big, huge cysts in the glenoid. So this is a newer innovation. Anyway, I got the scissor to cut it. I think we put one more anchor in here to finish that, but I was just showing you those two right there. Slap tear, similar, just real quick. I don't have any video on this, but so remember, slap tear is at the top of the clock, 10 o'clock, 12 o'clock, 2 o'clock. And here's the bicep tendon, and look at this separation. This is that peel back mechanism that it's separated. It's unstable right there. This part and that part are all good. This is not an anterior. It's not a posterior Bankart. This is a slap tear. And so we do the same thing, put our guide in there, drill our holes. We, again, put our little anchoring devices in, and when you get done, you get this look. So you get these sutures here now, these sutures here into that little anchoring place, and then that holds that into position so that that peel back mechanism is eliminated. So anyway, so that's kind of what we had, and I think we'll do questions and go from there.
That first group of situations you showed us, would you throw adhesive capsulitis into that? Where you talk about infections, and what's the youngest you can expect to see adhesive capsulitis?
I think it's 40-year-olds, 50-year-olds. So big difference between frozen shoulder and adhesive capsulitis. Adhesive capsulitis is really an autoimmune process. It's associated with diabetes. So a kid that has diabetes, insulin dependent, could have an injury and get an adhesive capsulitis. But usually most of these kids are going to get a frozen shoulder, like a limited mobility, because they've had a fracture or one of those kind of things. But usually you can work through that. Adhesive capsulitis is one of those things you live with for a year to a year and a half. It doesn't go away. I don't think that exists in the high school athletic population.
And if you have multiple contusions to a clavicle area, not a fracture, could that lead to thoracic outlet syndrome?
I think so. I mean, I think that the bruising of the brachial plexus and things like that could cause it to be more edematous. Thoracic outlet is one of those really weird things that just kind of comes and goes and you're not really sure how to manage it. And you're working on a lot of exercises to elevate the shoulder so the outlet, I showed those nerves going between the clavicle and the scapula. When those become compressed, that's when you get it. The more they're apart from each other. So I guess theoretically, if you had an injury and had swelling there, you could. I don't think I don't think the bone's gonna get bigger and crowded, but the soft tissues could.
What is your favorite test, like favorite special test in clinic to determine if it's a labral tear? I know a lot of people have different ones.
Yeah, I just usually put them through a big range of motion. So I look to see whether do I think they have a labral tear because they're unstable? Or do I think they have a labral tear because they have internal impingement, so they just, because you can get just that wear and tear. So for me, the label is going to be doing the apprehension test. So if I lay them down, I've got them in this cocked position, I'm going to lean back on them. And if they start to come off the table, then I'm going to leverage back into it. So do the relocation test. So leverage them out, relocation. So that feeling better. I mean, that's usually indicative of any kind of labral problem because they don't like that ball pushing up on the socket. And if the ligament's torn, they're worried about it coming out of place. So you'll get a much higher level. I think also if you're just talking about labral tears, I normally can feel it, so because the shoulder joint is not rigid together. I examine a lot of kids when they're asleep and I'm doing a anterior Bankart repair on them. Many times when I examine them, I can push them right out the back. It's very disturbing, because you go push them out the back, but you're doing anterior surgery on them. But they control that because remember, stability is ligament driven, but it's also rotator cuff driven. So if they don't have a good strong rotator cuff, and that's how those kids do it. They're kind of good mobility, but when they're asleep under anesthesia, they have no protection, and you can push them out the back and forward. So you have to look at both sides. So if you examine the left side and it goes all the way out, and you go to the right side and it goes all the way out, that's probably normal for that. Posteriorly. Anteriorly, that would not be the case. But I look for apprehension and I just kind of get them to relax, and that's a big problem too. And I just move them around and I'm kind of just leveraging into different positions, and then I see whether I can pop them in or out.
Are you able to briefly describe how many types of slap tears there are and what are the most common you see in the clinic?
Yeah, well, I mean, they talk about 4 different types, and really the repairable ones are the type 2s. So that's what we showed. So the type 2 is typically that at the 10 and 2 o'clock position, that's still attached. And it's kind of the bucket handle one so that it is separated, so that will move, but the 2 ends are still attached. Type 1s are really stable, and so they're usually just debrided. And then type 3s and 4s, which really relate to how much biceps injury there is, and then separation. So if the 2 o'clock position is torn away, then there's only one place. So the biceps is now pulled it completely off and it's only attached in one place. I think a lot of people, I did too, did a lot of repairs on those thinking you could just repair that. The problem is that doing a slap tear requires perfect tensioning. If you over tension the slap tear by any degree, they will develop terrible bicipital groove pain because it's very specific as to how much pressure there is. Because it's tightly wound. And kids, when I do their shoulder scopes for something else, not uncommon, the biceps isn't tacked right down to the glenoid. It's a little bit separated, and that's their normal deal. So when they have a slap tear, where do you take them to? Because if their normal is to be a little bit loose and they've torn and they're up here, do you bring them down to a little bit loose or do you bring them down all the way to the bone? And I would say you bring them to the bone because that's where the best healing is going to be. But that might be 3 millimeters tighter than what they've been their whole life, and it will screw them up. So when I do slap repairs, I am very particular about whether or not I think I can reestablish what that is exactly. Because if I can't, I'd rather do a tenodesis. So I would just say, so it depends on who they are. If they're throwing 103 mile an hour fastballs, you got to figure it out because you can't take away their biceps. But anybody else, who plays and does sports, if their biceps is just, if you say, screw it, I don't think I can make that perfect. And I spend a lot of my time taking down slap repairs, so that's why we're kind of tainted that way. If we just move the biceps from the attachment to the glenoid and put it into the groove, it'll still be powerful. It'll still do what it needs to do, but the tension no longer makes a difference. And so it goes against your grain because you're wanting to fix it and make it right. But the reality is that many of these kids that have that done do not do well. They just get this chronic pain and problem, and they would have been better off just releasing it. Brett Favre, when he left us and went to Minnesota, went down and had his biceps cut so he could go play for Minnesota Vikings, so you can play a professional level without the long head of the biceps because you have the short head, and the short head is capable of doing all the biceps curls and all the activity. It's not capable of throwing 103 mile an hour zone, because then you do need that lever to keep that ball situated because the rotator cuff would not be powerful enough by itself to do it. But that's really the only thing you need it for.
Dr. Spears, what are your thoughts on the use of, in the rehabilitative side, cuff weights versus bands? I mean, in our world, people get handed bands, or we come from therapy with bands, or we have cuff weights, our limited budgets.
So we have a band with a big 0 and an X going through it in our clinic that sits up there. So I don't oppose bands for everything because I think there are benefits for them. But I think when you're doing, you have to decide what you're doing. If you're trying to work on bicep strengthening, fine. Rubber band tubings are very convenient. I have no problem with it. But if you're trying to do rotator cuff strengthening, there's no question that the rotator cuff is not a power muscle, it's an endurance muscle. It has to be trained in an endurance mode, okay? So endurance for us means 1, 2, or 3 pound weight, even for the big dudes, 1, 2, or 3 pound weight, and 3 sets of 15. And you're trying to build up to that. And the problem I have with rubber band tubing is that how many pounds of pressure is your rubber band tubing? And I'd like to know within plus or minus 1 pound.
Green.
Okay. Green. Right, green. And how much pressure will it be tomorrow? And how much will it be in a week? And the problem is you have no idea. And so when you're trying to see, am I making progress with my rehab program? How much does a 1 pound weight weigh? 1 pound. How much does it weigh in a week? 1 pound. So if you can do 1 set of 15, then you can do 2 sets of 15, you can do 3, then you are making progress. And you are actually activating the muscles. So there were many years ago, there were studies done that looked at, they did the whole EMG thing where they measured it and they took, and you say, well, why is it 1, 2, and 3? Because what happens is when you do 20 pounds, your rotator cuff is contracting. There's no doubt about it. But your deltoid and biceps are way over contracting because that is their job to do. They're the 20 pound lifters. When the weights go down, I don't know what the exact number would be, but when you get down to 3 pounds, the deltoid becomes disinterested. It doesn't need to be involved in that activity. So the point of the 3 pounds or 2 pounds or 1 pound is to isolate specifically the rotator cuff muscles exclusively. That's what you want to do. And so the lightweight high repetition does that for you. When you're doing a rubber band tubing and there's 15 pounds of pressure, great, but you're not really isolating the rotator cuff anymore to do it. Now, when I'm trying to do negatives, so I got a pitcher and I want them to work on deceleration. So I've got a rubber band tubing and I load it back here and I say, okay, you hold it, and it's pulling them towards the door because I'm trying to get their infraspinatus and teres minor, their decelerators to work. Then I love that. I think the negative part of it, the isometric kind of part of that can be really good. And doing negatives for your biceps. So you hold it and it resists you, right? So negatives are the muscles lengthening while still contracting. That's hard to do. That's really good to do with rubber band tubing. But that's an advanced program. When you're doing negatives for deceleration, which is important in a pitching program, when you're doing a return to throwing program and they've had a labral tear, you got to reestablish their eccentrics. Because they're going to accelerate to 100 miles an hour, but they got to go back to 0 at some point. Or else the arm wraps around the body. And so that deceleration becomes important, but they've got to first establish the rotator. And that's the 3 pound, 3 sets of 15. They can do it, no problem. Then everything comes into play. They can do machines, they can start doing bench pressing, whatever, and then the negatives come into place. And I think that's where the rubber band tubing come into play. And then the problem with rubber band, or the thing with rubber band tubing is super easy. They cut off a piece, here you go, take it home, there you go. But so is a 1 pound weight. I mean, you can get a can of beans or something at home and figure it out. And you just have to understand what you're doing. If you're doing negatives, great. If you're doing biceps, fine. But if you're doing rotator cuff conditioning, anything outside of lightweight high repetition really doesn't isolate the muscle as well as it should. And I think it's hard to check their progress. You want to see how they're doing and how they're feeling.
Dr. Spears, throwers, pre-game, post-game activity, what's your recommendation for our activation of the muscles with the band exercises, things like that prior to throwing, and then post-game, what's your recovery?
Well, I think they should do a dynamic workup like we talked about with everybody, but some, you got to talk to the pitcher. Some of them, if they lift one weight, they think they've lost all their power and strength for that day, so they want to do more stretching and they kind of do a little bullpen workup. They like to do. I think you should get them doing activities because I think your body needs to get ready for it. If they just throw, remember your power in throwing all comes from it's coming off that rubber and pushing off in your core and there. So I think working on that and getting that dynamic workup so you're ready to go, because you're not hitting anybody, but you are throwing. And if you don't have that part warmed up and you've just thrown some balls, then I think you're going to be behind. And I think at more risk for injury. So I'm still into the dynamic workup, making sure they're well hydrated, they eat enough and all that. And I kind of see what they like to do. And I just like to make sure that it's adequate. If they say, well, I just throw 3 pitches before I start, that's not adequate. But they don't need to do an hour's worth of working out because they might feel like it takes some of their energy and they don't need it. But they ought to be working on their core and on their legs, do some running. All those things should be done. They probably should break a little sweat before they throw.
I think we all use bands as in a prehab capacity for, I make for my softball, baseball, just a prehab warm up of okay, just do 5 D1, D2s with a band.
Mm-hmm.
Do you think that we should get rid of that? Stick with it just for a warm up?
I think you need to include the other weights.
Yeah.
I don't have a problem with the rubber band tubing and having them do the negatives. And if you're wanting to say, hey, I just want you to work on your deltoid and you're going to pick that arm up, but you're not working on the rotator cuff. And I think in the baseball world, that's a huge overhead throwing. That's where they get their breakdowns and they don't have their stabilities. And so I just think that and the kids look at you like, are you serious? A 2-pound weight? But make them do it 45 times and it'll get their attention. And that's what I tell the kids. I said, well, you know what? Take that 3-pound weight, turn your thumb down and do 45 for me right now. And they'll get to 22 and they'll go, oh my God, and you say, yeah, exactly. That's exactly what the problem is. And if they can do the 3 sets of 15, which they should, then they're good. Then that's just the reinforcement that, my rotator cuff is stable, it's doing what it needs to do. If I can do the 3 sets of 15, pretty much. Because if it's torn, you're not going to be able to do that.
How often do you see I think it's called the OS acromial,
Yeah, pretty often. Yeah, so the os acromiale, so that's a growth plate in your acromion, and there are meta and naso acromion, so it depends on where it is in it. They can be a problem a little bit. It's not common though. It's a growth plate that didn't fuse. And so usually it's fairly stable in this age group. When we operate on it, it's a problem because we have to work around that growth plate. And sometimes we have to take out extra bone because of it when we're doing mostly our rotator cuff type stuff. I haven't had a lot of kids with it. I read articles about injecting them and doing stuff with them, but for the most part, in a younger kid, that cartilage and everything is still very stable. Okay. And so you see it on an x-ray, but it's not usually the problem.
So when we have kids with, just no reason, rhyme or reason for shoulder pain and that kind of thing, how often should we consider that as one of the issues?
I don't think it's a big deal.
Okay.
That's not anything that really comes up that we think it's a problem. It's usually going to be more muscle driven or labral driven and again, almost all these kids are muscle imbalance problems. The rotator cuff tearing and I'm talking about the atraumatics. So they're coming in, you don't know why it is, they don't know why it is. It's usually not the proper conditioning, imbalance of the muscle, just not doing the right conditioning they need to do. That 90% of the time is what it is. It's not usually a tumor. It's not usually some loose body. That's one of those things, could it be a sexually transmitted disease? Could it be Lyme disease? Those little things come up. But again, in the last 10 years, we see 4 people in our clinic with Lyme disease. So it's not an incredibly common thing, but when it happens, you go, it's pretty, wakes you up that, wow, I didn't know that. So I think ice coming out is not so big.
When you think about ice for like recovery and stuff, like I think
Yeah.
that research these days has been kind of getting away from ice for recovery, like, what do you think about that?
I guess I don't think about that.
Like,
I mean, I'm too old school to change now. I mean, we've been using ice forever. I think you can study it however you want. I think there's benefits to heat. I think there's benefits to ice. I mean, I clearly think that people are, post-operatively, people are helped with ice therapy with no doubt about it. So whether or not long-term it makes a difference, I don't know. You can talk about, when I do a lot of my surgeries, I use CPM machines and I'm bending their knees and stuff. And I do it on shoulders, I do it on knees. And there's a lot of research that says in the end, it doesn't make a difference. But for the first 6 weeks, it does. So yeah, and that may be the same thing with the icing, that maybe there isn't in the end anything different. But I think when that kid's hurting, you put ice on it, I do think it makes a difference. And so until I come up with a difference, so if somebody said, well, here's what we're gonna do instead, prove to me that it works, but right now in the training room, I think it's one of the best tools you have. So I'm still about it and I don't see any reason to quit doing it.
Usually if you've got nerves, you've got blood vessels. So if you've got a nerve injury, could that also mean that loop of blood vessels going around the humeral area could be damaged? And how would you detect that?
Well, yeah, I mean, whenever you get an injury, there's always going to be a blood issue. Tearing a muscle, there's, again, we talk about big arteries, but there's all the capillaries and the micro arteries and mid-size that can get damaged. I mean, I think usually the difference is that an artery and a vein can have stretch to them and recover. The problem with the nerve is you can't stretch it. If you stretch it, you damage it. Because the fibers become damaged. So a muscle, a nerve with an artery and a vein all around it. I mean, we talk, I guess we talk about knee dislocations. You have a knee dislocation and you get a terrible arterial injury, but you also get nerve injuries. And many times the nerve injury occurs and becomes permanent and the artery doesn't get damaged at all because it does have the ability to flex and to move, stretch, and then not necessarily bleed. So I guess that's the difference to me, is that the nerves are very susceptible to the stretching part of it that damages them and they don't work. Whereas an artery can be stretched and still function and do what it needs to do. But smaller ones, I mean, I think that they bleed, you get hematoma formation, and sometimes it's really huge and black and blue, and sometimes it's not. It's probably dependent upon how much bleeding occurred from the injury.
Do you ever see myositis ossificans in the shoulder anymore?
No, I haven't seen the quad and stuff, but that's really, and we don't see much of that anymore. We're on that. We treat it more quickly. We don't sit them around, and so I mean, I haven't seen a case of that forever, really. But I've never really seen it in the shoulder. I've always seen it in the muscle. I think you need a big enough muscle for that hematoma to set up in there. There's probably not a big enough muscle in the shoulder.
In football, it was usually related to consistent pounding over a period of time.
Yeah.
So they had the deltoid pad that came down from the shoulder pad.
Right. Yep. Yeah, I don't see that much of it though.
Any other questions for Dr. Spears before we dismiss him?
All right.
Well, thank you very much, Dr.
Thank you.